Good morning, everyone. It's wonderful to see everyone after this nice long weekend. I'm Marina Toulouse-Shams. I'm the Division Director of Infant, Child, and Adolescent Psychiatry and Deputy Vice Chair for Research at Zuckerberg San Francisco General Hospital. And today I have the distinct honor and pleasure to welcome Dr. Sarah Vinson, Associate Professor of Psychiatry and Pediatrics at Morehouse School of Medicine in Atlanta. Dr. Sarah Y. Vinson is a triple board certified child and adolescent, adult, and forensic psychiatrist, a proud alum of Florida A&M University for undergraduate. She graduated from the University of Florida College of Medicine as an inductee in the Chapman Humanism Honors Society and with research honors. She then completed her general psychiatry training at Cambridge Health Alliance, Harvard Medical School. This was followed by fellowships in both child and adolescent and forensic psychiatry at Emory School of Medicine. In her associate faculty position at Morehouse School of Medicine, she was the lead architect and is the program director for the Child Psychiatry Fellowship, the first and only at an HBCU medical school. She is also adjunct faculty at Emory School of Medicine. Dr. Vinson is the co-editor of two texts, Social Injustice and Mental Health and Pediatric Mental Health for Primary Care Providers. She has written book chapters and peer-reviewed articles on the social determinants of children's mental health, child trauma, social media, and children's mental health, fostering resilience, the criminalization of mental illness, and the school-to-prison pipeline. Her work is really incredible, and I suggest everyone pick up her books at minimum. She has received multiple awards in recognition of her leadership and service, including the 2020 City of Atlanta 40 Under 40, the APHA Sampson Minority Fellowship Alumna Award, the University of Florida Outstanding Young Alumna Award, and a NAMI Exemplary Psychiatrist Award. Dr. Vinson has been elected and appointed to national and statewide office by her professional peers. She serves on the board of the American Association of Community Psychiatry and of the Bazelon Center for Mental Health Law. She's been an invited speaker at numerous events, including the American Psychiatric Association annual meeting, the National School-Based Health Conference, the National Urban League Conference, and the Congressional Black Caucus Health Brain Trust. Dr. Vinson was appointed by the Georgia governor to the 24-member Behavioral Health Reform and Innovation Commission and is the Child Subcommittee Chair. So you can see now why I have the honor and distinct pleasure of introducing Dr. Sarah Vinson. And please join me in welcoming her to speak to us today about social injustice and mental health. Before we start, I just want to say that there will be a Q&A session at approximately 9:20. If you have questions for Dr. Vinson, please submit them via the public chat box. Thank you.
Thank you so much for that introduction, and thank all of you for having me virtually with you today. And so we'll get right to it, talking about social injustice and mental health. And as mentioned, I'm the co-editor for that book, and that's my disclosure. I also want to mention that I do forensic work and have a practice, and not that it has to do with the content of this talk from a sort of disclosure standpoint necessarily in the traditional sense, but it does give me a lens on a weekly basis as to how things are different in a public clinic versus a private clinic, and the ways in which our mental health care system's workings and failings have implications in the juvenile justice and the adult criminal justice context. I also want to acknowledge my co-editor, Dr. Ruth Shem, for this book. I know that she's spoken with you all before, and you know that she's fantastic and has really been a tremendous mentor and sponsor for me. And so just wanted to acknowledge that. And she's got a few slides in here as well. So what's ahead? We will be starting with a brief introduction, discussion about mental health care, about child trauma, about the carceral system, looking at substance use disorders. And then hopefully at the end of all that, there'll be some part of you that wants to do something about the things that are laid out. And so we'll transition into advocacy and a call to action, followed by the discussion. And I prefer to call Q&As discussions because that's what I hope they end up ultimately being. I don't think that any one person holds all the answers or all the knowledge, and I really welcome bidirectional exchanges of information. So defining mental health. So the World Health Organization talks about it as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully and is able to make a contribution to her or his community. And I start here because psychiatry and medicine often have a more deficit-based orientation. It's the way that we're trained. It's the way that we bill. It's about diagnoses and what's wrong with people. And I want to level set that when we talk about mental health and mental well-being, when we talk about the goal that we should have for our society, for the people we serve, it's not just the absence of symptoms. It's their ability to be full citizens in their families and in their community, through the normal stresses of life in a way that is adaptive for them. So defining social justice, and of course there are multiple definitions for this, but we'll use this for this talk. And from John Rawls, is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. And I think this is helpful as we go through this talk, because social justice has become this sort of lightning rod term, and in some circles is used in a really negative way. But when you look at what it actually is and what people describe it as, this doesn't seem as if it's something that should be all that controversial, especially for psychiatrists who are supposed to be about promoting health and allowing people to be those full operating members of society. But it is important to acknowledge that this is not a given, right? That in medicine, there is a civil war of sorts that's going on. There are people that are saying this needs to be a larger part of what we do and what we pay attention to. And there are grand rounds like this that are bringing everybody together to discuss these things. But we can't act as if there isn't some discord within the House of Medicine about where does the physician's role start and what is our lane. And Dr. Stanley Goldfarb had an editorial in September of 2018, and this is a man who was in a very well-respected institution in a very high-up position, who really bemoaned the introduction of social justice and social issues into medical curricula. And a quotation from that article is in the bottom left, and he said, "Curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness. And so will many of your doctors in coming years." And I thought it was interesting that he used treating illness and not promoting health, sort of getting back to that deficit model that we often fall into in medicine. So there was a response to this from some people at his own institution that in order to really be healers and to think about who gets sick and who gets care and how, that we do have to think about social and health policies. And one of those responses included a quotation that said, "Social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs." And so when we think about medical school curriculum, when we think about physicians, when we think about the privilege and the power we have as doctors, especially as psychiatrists, given the weight that the diagnoses we give people can carry, we have tremendous power. And there are ways that I think sometimes we can start to take that for granted because we graduated medical school with a whole class of physicians and we went to residency with a whole class of psychiatrists. And so it can become part of that background noise for us. But you are someone who is in an enormous position of privilege in the larger society, in the House of Medicine, in the field of mental health. And for us not to be aware of these larger issues of social justice is ignorance, and it's ignorance that has direct implications for our patients, their outcomes, and for the larger society. And there's a quotation by James Baldwin that says, "Ignorance allied with power is the most ferocious enemy justice can have." So as we think about justice, as we think about our role as physicians, as we think about what obligation we have to our patients and to our community to be educated about these things, I hope we'll be able to come back to this. Another thing I wanted to say before leaving this slide is that when Dr. Shrim and I started writing this book, when we first pitched it to APA Publishing, who was our publisher for the project, it was titled Social Justice and Mental Health. But as we went through the research, as we wrote these chapters, as we edited these chapters, we realized the story wasn't really about justice, that injustice is so rampant in our society. It was a misnomer to call it that. And that's why we changed it to social injustice and mental health. So this brings me to the American dream, that we are trained and taught from a very early age that this is a land of liberty and justice for all. America is framed as this place where there is opportunity for everyone if you just work hard enough and you're a good enough person. And this narrative can make it really difficult to think about systems level factors because there's this individualism that's sort of written into that way of thinking about things. And the people who have the privilege of going to medical school or becoming psychiatrists or going to graduate school and becoming psychologists or becoming master's level clinicians are people who are more privileged on average than the rest of the population, particularly when we think about physicians. They are more likely to come from high income households. And the people who didn't come from high income households are folks for whom the educational system actually worked. They're people for whom working hard and believing that if you put in the time, you get in good grades, will pay off, that was their lived experience. So I want to take a minute and pause and acknowledge the fact that our experience as mental health professionals isn't necessarily representative of the larger societies. We know that wealth gaps are increasing in America. We know that upward mobility is decreasing in America. So this is our experience, and our experience goes along with the American dream narrative, but that's not necessarily the case for many in this country. And for many of the patients you serve, particularly those who may have been born into poverty, intergenerational poverty, hyper-segregated communities, situations where they don't have the same opportunities. So next we come to health disparities. And often when you have the talks about social determinants or cultural competency days or these sorts of things, this is the term that's used. And the definition is differences in health status among distinct segments of the population, including differences that occur by gender, race or ethnicity, education or income, disability, or living in various geographic localities. And we juxtapose that with health inequities, so disparities in health that are a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. So with inequities, you're really pinning the problem on broader societal choices, on our systems, on the way that they work. With disparities, there's just an acknowledge that there's a difference, and that allows room for things that aren't helpful, and that may essentially end up blaming the marginalized party for the outcome. So I encourage all of you, when you're listening to talks and people use the word disparity, to do a little mental exercise and think if you can come up with a systemic, avoidable, and unjust social or economic policy that's actually driving that disparity, because there's typically an inequity on the other end of that. And so this is a diagram from the Social Injustice and Mental Health book, and it built upon Dr. Shim and Dr. Compton's book, Social Determinants of Mental Health. And in the middle, you see things like homelessness and housing and adverse features of the built environment, low education, adverse early life experiences. And we're understanding more and more that so much of what makes people sick, of what helps people be well, has a lot to do with what's in their environment and not what happens in their 30 or 1 hour minute, 30 minute or 1 hour long session with us. But when we think about what are the determinants of those social determinants, what's driving those social determinants, what is setting them up, and what is the orchestrator for those determinants, it comes down to unfair and unjust distribution of opportunity. So as we think back to that definition by John Rawls about what social justice is, this is ultimately a social justice issue because that opportunity is not equitably distributed. And how that distribution is determined is by public policies and social norms. And these two things work together and influence one another to create and set up these systems. And so if we just start with the social determinants, we miss an opportunity for a more upstream intervention that could have more longstanding impact on how our society's health is. And these are other terms you may hear, and I think this picture is helpful for thinking these through as well, and why equality isn't always enough, and why equity may not always be your goal either. So with inequality, it's clear one person has the opportunity, one doesn't. With equality, you're giving everybody the same thing. And sometimes you'll hear people talk about this as the goal. Well, I treat everybody the same, and we're all equal, and we're all more alike than we are disalike, which sounds nice, but when you do that, you're not acknowledging the fact that the system isn't the same for everybody. And so giving everybody the same tool isn't going to result in the same access. With equity, you're giving custom tools that identify and address inequality. But the goal is that the system is adjusted, that the system is fixed so that there is equal access to both tools and opportunities. It's going to take a while for us to get to justice, and hopefully that'll be clear by the end of the talk. But in the meantime, hopefully we can think about ways to be more equitable in how we deliver care. So some principles of social injustice that I wanted to point out and that I hope you'll think about as we go through some of the examples later in the talk are essentialism. So the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. So some of the ways that we can see this show up in medicine are well-intentioned cultural competency days where they say Asian people do this, Latinx people do this, Black people do this, and they have 3 or 4 adjectives that are supposed to describe an entire community that is quite multifaceted and diverse. And that really reduces the nuance of the culture, and that flattens out who those people are. Biological determinism, so the false belief that racial groups are biologically and genetically different. And of course, we still hear this in medicine at times. Erasure of context, so failure to consider socio-historical context when seeking to understand the etiology of inequities. So when the inequity or the difference is placed in the individual or in the person without taking a step back and looking at the issues in the broader society that could be contributing to or driving that. And then structural racism, a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. And then types of oppression. So as you're looking for those things, also look for these from the system to the person or to the individual. So exploitation is the unequal exchange of one group's labor and energies for another group's advantage and advancement. Cultural imperialism is establishing the ruling class as the norm, othering of groups that are not part of the dominant culture. And we actually hear this a lot in medicine when they'll say things like Asian people are more likely to, or Black people are more likely to, or Latinx people are more likely to. You hardly ever hear white people are more likely to, right? And it's because as the ruling class culture, they are the invisible norm and everybody else is compared to them, and things that don't fall into that are othered. Powerlessness is when oppressed groups lack power and are blocked from routes to gaining power. And we certainly see this in the US based on socioeconomic status, based on race, but also in the population that we serve with mental illness and the stigma that accompanies that as well. Marginalization, so expelling specific groups from meaningful participation in society, and violence, threats and experiences of physical and structural violence. And I want to sit for a minute with structural violence. I think physical violence comes quite naturally to us in terms of understanding it. But structural violence may be newer to folks. And with this, It is when a system, as it regularly operates, is actually causing harm to an individual or to a community. So a prime example of that would be a chronically under-resourced school system that has a young girl who has a learning issue that has not been identified, that has not been appropriately addressed. And when that girl acts out in frustration, rather than being given the educational tools that she needs, she is routed to the school to prison pipeline and sent to juvenile justice, which we know doesn't have a good track record of rehabilitating people and actually sets them on a trajectory to adult justice involvement. So that's an example of structural violence, something that she is made to participate in, that's part of this bigger system in society, and that is actually doing her harm. So this brings us to the mental health care system. And we see inequities throughout our system. This is something that isn't new to you as people who operate within it, but just wanted to take a step back and think about how we got here and why we are where we are. And so with hospitals, this is the place where people are supposed to get well, where the sick are healed, where people find relief, but they're not necessarily placed in the communities where there's the most relief needed or where there's the highest concentration of illness. And we see that we have hospital inequities in terms of where services are provided and what types of services are provided. And these inequities are the result of a confluence of residential segregation, hospital imperatives to generate revenue, and state policymaking. We see that hospitals, clinics, do cluster in areas depending on socioeconomic status, but it's not just socioeconomic status and funding, public versus private, but race also comes into play as well. So when you look at, for instance, mental health clinics and Medicaid in communities, it's not just having a high Medicaid rate in a community that decreases the chance a mental health clinic is going to be there, it's having a high Medicaid rate and a high proportion of minority people there. Physicians, so the pipeline, the folks who end up becoming psychiatrists, go through this, as you know, very long, drawn out process to become psychiatrists. And part of this can be traced back to the Flexner report when we look around and we see the lack of underrepresented minorities in medicine and in psychiatry. So if we go back to the Flexner report, before it, there were many more medical schools that were focused on training minority physicians and training women physicians. After those standards came out, it really favored institutions that had more money, that had more facilities. And so a lot of schools were shut down, and disproportionately the schools that were shut down were schools that served Black people and women. That was followed by segregation of medical schools, so they could no longer go to their schools because they had been shut down, but they weren't allowed to the other ones. And then we did see some progress, but then we saw this backlash with anti-affirmative action policies and a lowering of underrepresented minority medical students and physicians. And then in health insurance coverage, we've seen how racialized terms and political movements have proven to be barriers to health insurance and to coverage. And we've seen consistent efforts over time, as we've also seen in recent years with the attempts to undermine the ACA. And so this is something that you could certainly have an entire talk or an entire seminar about, but I wanted to get to some of those other examples as well. But episode 4 of the 1619 project has some good additional information on this if you'd like to learn more. And so if our mental health care system is supposed to provide care for people with mental health problems, let's see how it's doing. In 2018, 69% of Black adults with any mental illness received no treatment, and 42% of Black adults with serious mental illness received no treatment. So when we say a mental health care system, care is not being provided for people who have mental health needs. 67% of Latinx adults with any mental illness receive no treatment, and 44% of Latinx adults with serious mental illness receive no treatment. And when we come to substance use disorders, the numbers are even worse. So 89% of Latinx adults with substance use disorders reported receiving no treatment, and 88% of Black adults with substance use disorders reported receiving no treatment. So these numbers sound really bad, right? Like all these people who need care that aren't able to access it, given the way that our system is configured. And when we think about this in the broader context, of who has opportunities and who has room for error in the broader society, these same racial groups, Latinx and Black people, are the ones who are overrepresented in the criminal justice system when it comes to substance use, even though we know that substance use is about the same across races in this country. So the lack of treatment for these populations has even greater implications potentially because of that criminalization. And so there are all these things like caps on coverage, such as limits on number of visits or days, cost sharing, benefit limits, low reimbursement rates, and no coverage in some instances that make our system inaccessible to people. The way that our system is configured also drives psychiatrists out. And so some may opt out of Medicaid, may opt out of private insurance networks, do cash-only practices. And what we have as a result of that is that the proportion of mental health services received out of network is 3.6 to 5.8 times higher than other medical specialties. So this issue of inequity and injustice really affects our field in mental health in a way that's distinct from other fields in the house of medicine. And I ask you to think about when you've been in talks about health disparities or differences across race with treatment engagement or outcome, how often are these things brought up? How often are these things tied to what we know are really significant wealth and income gaps across races, and how these things could all be working synergistically to make it difficult for people to access the system? Often, instead, in our cultural day or cultural competency talks, we talk about stigma and culture-bound syndromes and all of these things, but there is an acknowledgement of the role that our system plays. So what happens when you ask people why they don't get care? So this was a study that actually asked Black people, why don't you get mental health treatment? And what they said is cost is the most commonly cited reason for not seeking care. And this was twice as often as minimization of symptoms and nearly 5 times as often as stigma. So the narrative that we are often fed is, oh, they have stigma, or they don't have insight, or they don't understand what mental health treatment is, and there needs to be education. Sure, education is good, but there also needs to be access and affordability for the care that people need. So shifting into substance use disorders. So as we saw, our system, our mental health care system often is not reaching all the folks who need help there. And there's a way that how society thinks about substance use disorders directly impacts the resources they're willing to put into the mental health system in order to treat substance use disorders. And that impacts that high number of people who aren't getting treatment. So something that's helpful to think about when it comes to substance use disorders is the story behind it. And one of the things that we see happen in this country is moral panic as it relates to substance use disorders. And so the steps of this are that someone or something is perceived and defined as a threat to social norms. News media and communities depict the threat in symbolic ways. Widespread public concern is aroused by these portrayals. Authorities and policymakers respond to the threat with new laws or policies, and these actions lead to social change in the community. And so a prime example of this is how crack was discussed and how it is still discussed. And the way that the mothers were talked about, the way that they were depicted, the way that crack babies were discussed, all fed into this frenzy and this response that was really harsh and punitive, that treated crack differently than cocaine, and that had this impact on an entire generation of people. Now, there have been some things to correct this drug disparity in terms of sentencing, but it's not completely corrected, and you still have families and individuals who are dealing with repercussions of that. It's not a coincidence that the moral panic associated with crack was not with cocaine, right? Because it fed into fears, stereotypes, negative characterizations of Black people, of Black mothers, of Black families. And so they worked together to create this dangerousness that was attached to this drug versus other drugs. And because of that perceived dangerousness, there was this really harsh response to them. And we saw that care, and I use that term facetiously, was shifted from the mental health care system to the adult justice system. And Ernest Drucker, in A Plague of Prisons, said the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. My mother is actually a probation officer, a former police officer, and she does it in a small town, Northwest Florida. So they have a lot of drug offenses for people who are on her caseload. And one of the things I remember her talking about was how if people came into her office and they wanted treatment, they could never get treatment on the same day. It just wasn't a possibility. Even if you had money, it wasn't an option. But if they got in trouble, if they were found using that substance or in possession of that substance, the justice system was ready on that very same day to lock them up, to charge them, to separate them from their family, to disrupt whatever employment they've been able to string together. And it was an illustration of where society chooses to put its resources and how that allocation of resources determines people's experiences as substance users. And so we can juxtapose, right, the moral panic that went with crack babies and crack mothers with how the current drug epidemic is being treated. And I want to also acknowledge that crack is still a problem. Meth in rural communities is still a problem, but you wouldn't know it looking at news coverage. You wouldn't know it looking at the APA substance use disorder page. And why is that, right? So when we look at the opioid crisis and we look at the population that is affected by it, it is a population that is not thought of as being inherently inferior, inherently bad, inherently immoral or violent. The population affected by it is one that lawmakers, people who drive stories, people who write stories, people who write laws relate to, and that they don't dehumanize in that same way. And as a result of that, we've seen a very different response, not just from the government, but from our field of psychiatry to this particular problem. So moving into child trauma. So when I was at Cambridge, I had the incredible privilege of working under Dr. Judith Herman, who wrote Trauma and Recovery and was the first to talk about complex PTSD. And it really has framed my career, having that experience so early. One of the things that she says in the book is the developing child's positive sense of self depends on the caregiver's benign use of power. And in that, she's talking about primary caregivers, so parents, grandparents, folks in the household. But I would posit that as a society, children's caregivers don't stop at the home. When we think about mental health in that way that the World Health Organization describes it, their caregivers are also people in the educational systems, the child welfare systems, and so forth. And so how we approach children is part of them being able to develop into those adults that are able to contribute meaningfully to their communities and to their families. And of course, the mental health care system has a role as well. Thinking about inequity, it's good to have numbers, and sometimes it's good to go back to people. And these are three people that I've come across in my work in different settings. One was an adult defendant in a capital murder case. And we'll come back to his story, but he told me, I was proud to make it to 21, even though I was in prison. The second was a software programmer that I saw in my private practice clinic when I was asking him about his childhood history and adversities and things that he got to contend with. His reply to me was, school was all I ever really had to worry about. And the third was a detained teenager who said, they say I'm supposed to care about people when ain't nobody cared for me. And that certainly was his experience of life. This was somebody who had been in the home when his mother was murdered, shipped across the country to a caregiver who didn't know him very well at all, and had never received any sort of mental health treatment whatsoever until he was incarcerated on armed robbery charges. So we think about what children need. When we think about what those three people described, we know that stability and safety and security and opportunity are all important things. So having a true home, having a reliable caregiver, having educational opportunity and healthcare adequacy and access are all part of that solid foundation that we know sets people up. Child poverty is an issue in this country, and it is one that we know undermines all of those things on that previous slide. So 15 million, 1 out of 5 US children live in poverty. And this brings us back to sort of like the narrative and the way that we talk about things and the American dream and all of these things. If you Google image search for child poverty, most of those pictures don't look like they come from the United States, despite the fact that 1 out of 5 of US children live in poverty. And that threshold is defined as less than $26,200 for a family of 4. So as you can imagine, there are a lot of people who make $27,000, $32,000, maybe even $40,000, depending on where they live, and they may not be able to consistently meet their family's needs. And so when we think about it from a practical standpoint, because that $26,200 is not a very practical threshold, 43% of US children live in low-income families. While it is true that Black children are more likely to live in more income families, as are Indigenous children and Latinx children, by raw numbers, white children remain the majority, which is also something you wouldn't hear or see as part of the depictions of this problem. And this is in a country that spends $732 billion on defense, which is more than the next 10 countries combined, where a majority of US lawmakers are millionaires and 76.8% are men. So why am I pointing this out? I'm pointing this out because it's not that we don't have resources that could be allocated to this issue. It's that the people who are in charge of deciding where those resources go probably don't have lived experience with it and are clearly making choices that don't allow for this to be addressed. Now, I will say I've heard some positive things in the past few weeks. Actually heard politicians talk about child poverty and say those words. So hopefully we may be moving in a different direction. But historically, we have not done a good job of addressing this issue, of acknowledging this issue, of characterizing this issue in a way that's accurate. And when we don't address poverty, it sets children up, the children who become the adult patients that you treat, for a life that may not have that definition of mental health as accessible to them. So if you don't have a true home, things like housing instability, food insecurity, and depending on where you live, that also may come with exposure to heavily policed neighborhoods. Impaired caregivers, so poorly supported adults. I've always worked in a public sector clinic, child clinic throughout my career. And one of the things we have to come back to all the time is that the adults can't give the children things that they themselves don't have. And our safety net, particularly in Georgia, is really lacking for adult mental health care. A lack of living wage is something that we see definitely play into how families are able to cope and manage. Basic things like being available for appointments are really difficult if you don't have paid time off or if you have to work multiple jobs to make ends meet. They may have unavailability because of those social stressors that they themselves are under because of mental illness, incarceration, or work schedules. We know that segregation continues to be an issue in this country. It is not legal on paper, but we see it every day. And the kids who need more resources are in schools that have fewer of them. And what that leads to is the replication of extant social hierarchies. So if you're born poor without resources, you're at a school that's poor without resources. And so the idea that you're going to be able to be college or career ready is much more difficult under those circumstances. And it sets you up to be in that same cycle of poverty. And then limited access to healthcare with gaps in both coverage and capacity. So with Miguel, who said, and this is a changed name, I was proud to make it to 21 even though he was in prison, he'd been incarcerated from the ages of 17 to 21. And it wasn't because of something that he'd done that was violent or aggressive. It was violation of plan, which is what they call probation for kids, even though it's probation. He was found in possession of a small amount of marijuana, but his original charge even was a nonviolent charge. So he was incarcerated in an adult facility at this really critical period in his life for something that really didn't pose a significant threat to society. And when you look at his environment, a lot of times we would start at the family dysfunction. We'd talk about the intergenerational trauma with his mother and her untreated substance use issues and his father and all these things. But there are these other things that contributed not only to his experiences, but to his family's experience as well. So he was in a hyper-segregated community with tremendous neighborhood violence, lots of housing instability, and he was victimized by people in that community. But if we take it a step higher and look at the systems that were involved with his care, throughout his life, he was in 12 different foster care placements. And you would think one of them would have gotten it right when it came to his educational needs or his mental health needs, but not a single one of them did. So he had these educational needs that weren't met. He tried to, he made his first suicide attempt when he was in elementary school and was never in a residential or a higher level of care that would have properly addressed his issues. But the things that enabled that, right? The things that made it possible for a 6-year-old child to go through a system that put him in 12 different foster care placements were the decisions that were made at a higher level as it related to investing in his community and in kids like him. So it was a state with low mental health spending, 48th or 49th per capita. It had chronic child protective services, understaffing. And it was a time when there was a prevailing societal narrative that was very punitive toward adolescents. So you do adult time, you do adult crime, you get adult time mantra. And not surprisingly, the things that we see as a result of poverty and the structural traumas that people like Miguel experience are the same list of things that are risk factors for juvenile justice system involvement. So these other systems fail, and the justice system becomes a repository for all of those other system failures. So it follows that when you look at the kids who are justice involved, 70% have mental illness and 30% have serious mental illness. So whose trauma counts? We've seen some ways that systems don't serve many people well. And now it's time to look back at ours again. So when we talk about criteria A for PTSD, there's a lot of traumas it doesn't quite capture or acknowledge. And those traumas disproportionately affect marginalized groups of people. So something like chronic exposure to community violence or racial victimization don't make its way into our criteria. And why is that? Why is it that that's not acknowledged or seen or recognized by our field formally, even though it stands to reason that it could be something that would be harmful or detrimental? Whose trauma counts in our widely used instruments? So there certainly have been papers and instruments that have followed, but there's been this adoption of the 10-question ACE questionnaire that was developed in Northern California with a bunch of folks who are middle class who had Kaiser insurance. And again, it doesn't ask about things that are relevant to people from different kinds of communities. And so there's a way that in failing to recognize this trauma, we as a field, as a profession, can be bystanders to what occurs. And I have seen this time and time again in clinic and in discussions, but I also see this in my capacity as a forensic mental health provider. And there are absolutely implications of not recognizing community violence, racial trauma, marginalization, and its impacts on people in treatment and alliance building, and how their symptoms go. So there's implications there, but what I don't think a lot of mental health care providers understand are the implications in the criminal justice system. I have, in my forensics capacity, done chart reviews as I'm trying to do evaluations of people and help judges or courts or lawyers understand them. And the number of times that people in our field have overlooked a child's trauma and focused on his externalizing behaviors, given them a diagnosis of conduct disorder, completely disregarding all the things that they've experienced. It sets them up to be seen by the criminal justice system as incorrigible, is the word they use, as people who can't be redeemed. And it is very dehumanizing. And the failure to acknowledge the things that they've experienced by us, by people in our field, carries through in the criminal justice system. This is a clip, and I won't play it, but it was a young Black boy playing basketball in his own driveway. A police officer drives by and he stops playing, interrupts his game, and hides behind his father's car. When his dad asked him why he did it, because he saw it on the home security footage, the boy said, because they killed George Floyd. And there's a way that we pay attention to police officer killings and police violence because it's visible, because it can be recorded, because there's something very personal about it, especially in the case of George Floyd and the way that he was killed. There are ways that this system enacts harm on people every day that aren't as visible and that aren't as clear. So in the criminal justice system, or the criminal legal system, as you may hear it called, or the carceral system, because of the acknowledgement that it's not just, it's really not a question of whether it is fair or not. It reliably has inequitable outcomes. And in that system, we see that there are sentencing outcomes. So when you hold the actual crime or somebody's criminal history study and look at how their case is disposed of, there are sentencing outcomes that are different, not only by race, but also by how dark-skinned you are as a Black person. Most judges acknowledge that the system is racist. And this is in a case where 80% of state judges are white. So it's really not debatable whether this system is unjust or not. But I want to point out the role that we end up playing by how we talk about patients, how we frame their issues in perpetuating some of these injustices. And the way that this system interacts with other ones, including the school system. So this is the outgoing Secretary of Education in the state where she was critical in shaping the educational system. The major city, Detroit, Michigan, had a graduation rate of 23% for Black boys after her work was done. If you're a Black boy in this country and you don't graduate high school, you have a 60% chance of ending up in the criminal justice system. It is not that 77% of Black boys in Detroit, Michigan should be set on this trajectory to justice system involvement. This is a systems issue, and it speaks to where society's resources were allocated in that situation as well. And so I would ask you, going back to the definition of mental health and the definition of social justice, how can every individual realize his or her own potential, work productively and fruitfully, and make a contribution to her or his community in a society that fails to assure equal access to liberties, rights, and opportunities, and chooses not to care for its least advantaged members? And I would posit that it cannot. So that brings us to advocacy. And I just want to, I know I'm getting close to time, so I'll fly through this. But I would encourage you all not to feel overwhelmed by how big these issues are, and they are big, but to think about what power you have, where you are, and where you may be able to contribute. And these are all examples when it comes to education, trying to create and craft programs that have these issues front and center and infused throughout them, not just carted off to one day or one lecture a year. In the middle, I have Dr. Renelle Prim, who's this tremendous mentor and sponsor who has really shaped the careers of a whole generation of underrepresented minority psychiatrists who have themselves become leaders and program directors, myself being one of them. Trauma and recovery, which really, when we talk about whose trauma counts, counted the trauma of incest victims in a way that hadn't really been done before in psychiatry. In the top right corner is a mentor of mine who passed away about a year ago, but who was a tremendous advocate at the state level around policy changes that made things better for people here. And so 3 steps: developing a knowledge base, recognizing injustice and your role in addressing it, and responding through an iterative, sustainable process. Raymond Santana is one of the exonerated 5, formerly known as the Central Park 5. He was placed in prison due to a false confession at the age of 14 years old, spent 7 years there, and it took another 12 years for him to get justice through his civil suit. And I had the chance to interview him a few years back. One of the things he said is that we need all hands on deck. So this isn't a matter of all of you putting your careers in medicine and becoming community organizers or running for Senate. This is a matter of you working where you are and with the power you have, which is tremendous, to address these issues. So in the words of Arthur Ashe, start where you are, use what you have, and do what you can. Realizing that progress is always followed by retrenchment, that there will be pushback to what happens, and to use examples, things like the KKK in this country came as a response to progress that was made. We shouldn't be surprised when it happens. We should be ready for it and understand that it's part of the process. And I'll end with a quote by John Lewis, my former congressman. Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble. And thank you.
Thank you so much, Dr. Vinson, for that amazing rounds presentation. I have so much I want to ask you, but I'm going to open it up to the chat for discussion, as you adeptly described. So there's a note that thank you so much for drawing attention to the population the ACEs study was conducted in. That often does not get noted. And then many thanks and appreciate your public sector service. And then here's a question. Any thoughts on how our surveillance tracking infrastructure is contributing to systemic inequity, and what types of policies we might support to redress the inequities that accumulate through universal surveillance?
Yeah, I think about that more in the criminal justice system context and the way that can be used against people. And certainly when you have really densely populated communities, there are ways that people can be penalized because of where they live when they have very few options about living elsewhere. And there's been some publicity recently actually about the, what do they call it? They have like this gang database in LA, and just how kids as young as 4 and 5 are being placed on this thing because of where they happen to live. And so it's like any other system in American society, that the people who are in control of it could use it to further marginalize, groups of people. And it's something that we have to be mindful of. And the other thing that I think, I don't think this is your exact question, but I think it ties into it, is part of what we're seeing with reform, and we certainly saw this in Georgia, is that there's a push to get people out of correctional facilities, but that's being replaced by monitoring in the communities. And I think that there's an interplay between those two things.
Yeah, definitely relevant in the criminal justice side, big time, a lot to think about. I'd love to ask you a question about, and your book has this lovely chapter around call to action, and that you just ended with here. And you know, in psychology, I feel like we've been historically poor at advocacy. It's getting better, but even in integrating into our graduate training programs, our internships, and I really wondered if you could talk about how you think about integrating this work into training and the academy, and how do we make this valued in academia and in psychiatry departments? How do we think about that even as a form of advocacy in and of itself, and not just through our own mentorship and sponsorship? Because I think, as we know, for those of us who are engaged in this work, it's like feels like a small group, and it just happens to be those who are coming to be a part of your group, right? As you spoke about, even your own mentors and sponsors. So I just would love to hear your thoughts about that on a systemic level.
Absolutely. And I think, it's always helpful. I forgot the guy who had the TED Talk, but to start with why, right? So if our goal as a field is to help society and people be mentally healthy, this has to be part of what we do, right? Like the way that we have been doing it is not yielding results because we haven't addressed these issues. So I think it's helpful to start with level setting, like, what is it that we really want for our patients and for our society? And if we simply plug into a broken system, is that really benefiting people in the way that we say we want to benefit them? So I think it's helpful to start there. And then I think it's a matter of building it in throughout. So in helping people see this as part of their job as agents of promoting health, right? That this isn't some extra thing. This is part of our work as people who say that we care about people's mental well-being. And there are ways that we can do this, even though ACGME doesn't necessarily explicitly support it, right? But for instance, at Morehouse, and I had the benefit of building the program from scratch. So I didn't have to worry about things have always been done this way. I got to just do it the way I thought made sense. So for instance, we have a school rotation requirement for child. I could have sent them to one school the entire time, right? But I sent them to a state school that was actually sued for segregation because it's where they cordon off all the Black kids with learning disabilities. And the lawsuit is part of their rotation for it. Charter school in the inner city, and I send them to a school with a school-based health center in the suburbs, right? So they're doing their school rotation, but in that school rotation, the way it's set up, they're also learning firsthand about educational inequities. I'm having them look around at the neighborhood and say, where's the Subway? Where's the Starbucks? Where's the Wendy's? Where's the McDonald's, right? So there are ways that we can build it into those basic requirements that don't have it written in, but we can be intentional about how we structure it and asking those questions and prompting them to think about those things.
Yeah, outstanding. That's really novel way. I mean, it shouldn't be novel, but it is a novel way, right, of incorporating it in. And I think we could even do that with existing programs, right? Really assessing and looking at how are we thinking about the rotations in those ways as well. One last question. Do you know of any movements towards being able to bill for mental health as opposed to mental illness?
I don't. And that brings up for me, maybe tangentially related question about, just our billing in general, right? So one of the things that I struggle with sometimes is pathologizing what is a normal reaction to an oppressive circumstance. So I recently was writing up a report for or related to a man who was killed in police custody. And I really struggled with calling him anxious, right? He didn't have anxiety, he had fear. And he was afraid these people were going to kill him, and they did. So that's not really a codable mental health problem, the way that our system is constructed.
Yeah, we have a lot of work to do in that area around legislation and changing the coding and billing to come from that strengths-based approach and just all of the pyramid levels that you have discussed in relation to. So that could be a whole talk in and of itself too, right? As you said. I just want to thank you again, Dr. Vinson, for joining us. today. We are very grateful for your time and sharing of all of your experience and deep knowledge. So thanks again, and everyone have a lovely day.